Okay, I think we'll go ahead and get started. Welcome everyone to the fourth session of the Capture Falls Learning Cohort. My name is Dana Steiner and I work with the HQuick project through the Nebraska Hospital Association. Just the normal housekeeping things as we start a Zoom. Don't forget to keep your lines muted unless you are speaking. Add your name and who is all with you and what organization you're from to the chat. And then all of these are being recorded and there is a link on the NHA website where you can get to them. So if you go under the quality tab, then there's a drop down and then there's an HQuick tab. And if you go in there, there's all the recordings thus far on there. So this one will be uploaded that same spot. I haven't put slides on there yet, but I will. And the other thing is just talking about kind of today's meeting is going to be a little bit different in the format. It's going to be a little bit more of just kind of a question and answer time for people to really get some one-on-one help. Likely if you have the question, so does someone else. So please be interactive. The Capture team is truly the experts in falls. So if you have questions or things that could help, just talk them through. This is our chance to do that. So I'm going to hand off to, I don't know which one, Vicki, Dawn, or Anne, whoever is speaking first, and we'll let them get going and go from there. Thank you.
I don't know that we even know that, Dana. This is how casual today is going to be. And I appreciate you naming us as the experts, and we've certainly been studying falls and working with several of the hospitals in Nebraska on falls for many, many years. Much of what we've learned has been from many of you, however, and so this is going to be kind of a free-for-all that whatever questions people want to bring to the table, please ask. And we might not be able to answer immediately, or we might have to say, like, you know what, let's look into that and we'll get back to you. We might have to do that. But we also maybe will crowdsource a little bit and see if there's some audience members that maybe have a good answer or input on a question as well. You all have your boots on the ground. We work at the university, so we're not necessarily like in the trenches like many of you are. So I would really, really welcome the audience members to speak up and help each other out as well. So yeah, we don't have any content plan. It's just like, as you are starting to think about your audit, or maybe you've already tried, maybe you already did an audit, or whether you're still in that planning stage or whether you've actually done one the last 2 weeks, the last time we got together. We want to open this up to whatever questions you might have. So you can put that in the chat and we can just kind of go, with them in order when they appear in the chat. Or if you are a brave soul and want to unmute and verbally state your question, you can do that too. Sometimes it's easier to do that than put it into writing. Some of you might be here just to kind of lurk and listen to what questions others are hopefully bringing. I always joke with my students about that whenever we have a review for exams, some people come with questions and other people are just trying to learn a little bit extra by osmosis by just being around, and that's okay too. So
this is Amanda from Saunders Medical Center. And so I guess I have feedback and I guess a request for maybe ideas. We have done the fall risk education in the past. So it's revamping and gearing everybody up to not per se re-engage, because I feel like we have good staff that really are aware, but get those new above and beyond more fresh ideas for audits to make sure that we're keeping up with our top game. It's kind of getting at how do we spark that interest for re-engagement?
So is your question more about like motivation for staff to kind of keep
Yeah.
this at the forefront, or?
Yeah, I would say, and to really get that new audit. So auditing tools would be the idea to make sure that we're using gate belts appropriately and when intended, and how we get those on that peer-to-peer discussion about communicating to each other, and just being comfortable for everybody to go ahead and say, hey, oh, let me get a gate belt, or getting them to actually take that time to write it down on the audit instead of, oh yes, we really are doing that. Why is there another audit tool?
Okay, so I guess I would suggest you don't have to audit everything all the time. You know, there's so many things that you guys are doing to reduce fall risk. I mean, you're screening people, you're using gate belts for mobility, bed alarms for certain patients, you know, not leaving patients alone in the bathroom, you know, making sure the environment is uncluttered. I mean, the list can go on and on about all of the interventions that you guys are putting in place to protect people from falls. And so you don't feel like you have to audit all of those all of the time. You might want to kind of focus in your audit and kind of, I guess, validate why you are auditing certain things. I guess I would ask, are there certain things that you have noticed in some of your recent falls, or your most recent audit, if you've done audits, you know, not too long ago? Are there things that seem to be potential gaps in your processes? And then those would be the things that, in terms of what to audit, that would be the focus. And, you know, the motivation would be, you know, we're not doing great on this, so we're going to start looking at it a little bit closer, and just making sure you're, you know, communicating those results, you know, maybe, you know, like a pre-result and a post-result to your staff. You know, we're gonna look harder at gate belts because, you know, we've kind of fallen off on our reliability of using those on a regular basis. And so that's why that item ends up on your audit. And then, you know, probably just by virtue of looking closer at it, your staff is going to do better, and but then share back with them, you know, the positive results. It's like, hey, you know, we started focusing in on this and it got better. You know, of course, it could potentially drop off again. That's kind of human nature, but then, you know, that audit item ends back up on your list of things that you're checking up on. Again, you know, when it needs to be. It doesn't have to be there every single time you do an audit. So I don't know, Anne or Vicki, do you have any additional comments?
So Amanda, do you think, is it like a cultural issue with the gate belts? Is it something that people regularly use the gate belts, but then just sometimes they don't? Or is it more like, oh, I don't have time to get this gate belt on? I guess, do you know those factors behind why you're not using a gate belt?
Well, and at this point, it's not something that we see consistently all the time, and really not everything that we see in our current audit for falls is that we're kind of looking for new ideas and ways to kind of make sure that we're doing the right thing all the time. Excuse me. There are some cases where, yes, we're too busy, or oh, I just forgot. And so this was kind of something that was thought up that maybe we could be better at. We could maybe look at a little bit more closely, just to look at, maybe, is this a gap? Where, you know, are there trends somewhere that we could work on? So that's really where it's at. I think overall we're doing really good on it. Yeah, but we're just kind of looking at for things outside the box that we aren't already doing to just improve our process overall.
Maybe if you're looking for consistency, you can almost do something like rewarding for consistent use of the gate belt. So if you're doing auditing and just see how long you can go with everyone appropriately using gait belts or something like that, kind of like spin it to a positive. Hey, we're doing a really good job, but there's a few gaps that we might need to work on. So yeah, just making it like rewarding to use a gait belt.
I would say also empowering people to speak up, and I don't know if if your staff has engaged in Team Steps training at all, but there's a Team Steps tool called Mutual Support that, you know, it's basically like everybody has each other's back, and we're all human. We're going to make some mistakes sometimes and forget some things. And so, you know, if we're all looking out for each other, and, you know, even if it's like a CNA who notices that an RN on the floor is forgetting the gait belt, you know, just making sure that those staff feel that they're empowered to, you know, like, okay, that CNA can just grab a gait belt and hand it, you know, hand it to that RN. It's not, again, that anyone's trying to catch anyone doing anything wrong. We're all in this together, trying to make sure our patients are safe. And so those Team Steps tools, if you're familiar with that, or if your staff has been trained in that program, maybe dusting those off and mentioning those again could potentially help, again, kind of create the environment where everybody's helping each other out, making sure that some of those things that should be easy and no-brainers really don't kind of drop off in terms of habits.
Sure, yeah, and we're familiar with the Team Steps model, and the staff do a great job of that. So, and we'll keep plugging along, and I think we also need to get a little bit more education out there, but we'll keep working. But I really appreciate the feedback too.
We know it's challenging, especially when you don't like have a lot of falls. You just need to keep reinforcing, and it's not always so exciting all the time.
Yeah, Amanda, this is Vicki. One other resource, I'll make sure to send you the link to this. It's also on our Capture Falls roadmap. But I did a presentation in one of our collaborative calls a few months ago about how does human behavior fit into fall risk reduction. So as you're thinking about some of these issues of motivation and compliance and challenges with adopting best practices that we want our staff to use. That handout has a series of questions that you can kind of walk through to see, if we're running into challenges, is this a knowledge issue? Is this a skill issue? Is this a self-efficacy or a confidence issue? Is this something that's aligned with people's professional roles and identities? Are we having good role models on the floor, role modeling the implementation of some of these practices? Really trying to understand what people think about the risk of acting and doing versus not acting and doing, and how you make those decisions and manage those when you have competing goals, especially when you're really busy and have lots of patients. So I don't think I can drop the link in the chat since I'm sharing my screen. I don't know if Ann or Don, if you can, but otherwise I can send that handout to you as well. That might be another lens at which you can look at some of these areas. Some of the factors will help explain why some behaviors might be done consistently and why some may be a little bit more challenging to see consistency over time.
Okay, that would be nice. Thank you.
I see that in the chat, there's some questions about falls from chairs and what strategies are used to prevent falls from chairs in other organizations. We had some feedback. So we have chair alarms that beep when the patient tries to get up, and it also alarms at the nurse's station.
Yeah, and I can comment a little bit on this one. So as the physical therapist on the team, this is probably very much in my alley. So which, just going back to that last question, I was able to drop that link in the chat to that. It's just a PDF of the slides of a presentation that we did last spring for the hospitals and the Capture Falls Collaborative. So some of you might are familiar with that already if you were on that call, and others that might be new information, but that's what Vicki was just speaking to about the role of human behavior. In terms of chairs, I would say it's, it maybe depends. So are we talking about people like sliding out of the chair over time because they're not well supported, or are we talking about patients that are volitionally trying to get up on their own without assistance? So those, I kind of see those as two separate issues. And so, if they're trying to get up on their own without assistance and, to get up and go to the bathroom, and then they're falling, trying to get up on their own, as the was just clarified in the chat here. So certainly chair alarms are an intervention you can try. Those are especially important for patients with some cognitive impairment who may not be able to understand that they need to wait and call for help. So I wouldn't necessarily say that you need to have a chair alarm on everybody, however. So you do want to try to match your interventions to the impairments that those patients have. So if there's any sort of, delirium, dementia, a little minimization of abilities, people don't understand their own limits. If there's any inkling that they're not going to be able to be adherent with your instruction to wait and call us before you get up, those are situations that a chair alarm is a good idea. If the patient is cognitively intact and completely understands their limitations, then you don't necessarily need a chair alarm. Hourly rounding would be a good thing to have in place to prevent people from getting up on their own. And so if you can make sure you're doing that purposefully, to rounding every couple of hours and making sure you're attending to those needs. If incontinence is an issue or urgency, making sure that you're actually taking the patient to the bathroom every 2 hours, so that way you eliminate that motivation for the patient to have to get up on their own. That can be very important and can kind of head some of that off at the pass. Making sure that everything is within reach of a patient, again, just so they don't feel like, oh, they're getting up and going across the room to get their eyeglasses or whatever it is that they're after, is important too. So basically reducing the reasons they need to get out of the chair. Making sure they're comfortable in the chair, that the chair fits them well, that they're positioned comfortably in the chair. And what that looks like is going to be different for different patients. And so I would encourage you to work with your OTs and PTs to make sure if there's certain positioning strategies that could be used in chairs to make sure the patient's comfortable, and even to make sure that they're seated far enough back in the chair so that kind of speaks to the potentially sliding out issue, so they're not going to slip out of the chair. So those are some ideas that come to mind immediately for me. Janelle is asking, what kind of chair alarms are you using? Posey chair, pad alarm, or something different? And so I know, like, we don't necessarily endorse a certain brand or anything or type over certain others. I know there's the tab alarms that clip onto the clothing. Sometimes patients can be Houdinis and take those off, or there's the pressure sensing ones. So I don't know, I would encourage, if anybody, boots on the ground has any comments about a particular type of chair alarm that they like, I would encourage somebody to speak up and share that, because we don't necessarily endorse one or over the other. I think some work for some patients and some don't. Just depends on the patient sometimes. So does anybody from one of the hospitals want to speak to that? Nobody else has a solid answer either, apparently, of one that's, and none of this stuff is foolproof, and it's, AliMed is one that was put in the chat. It's not any single intervention that's going to work. Oftentimes it's a combination of interventions, that are going to work. So like a combination of an alarm, purposeful rounding, making sure the patient is comfortable so that pain or discomfort is not a motivation to get out of the chair. Making sure that, if that, toileting needs are taken care of. It's often a combination of all of those things. A lot of hospitals will place people who are a little bit more inclined to do that closer to the nurse's station, so there's eyes on them more frequently, or some hospitals have video systems in place as well, to, so you don't necessarily, you can have kind of remote eyes on the patient as well. So I don't know, Vicki or Anne, am I forgetting anything?
No, I think you covered a lot of it, Dawn. I was just going to add in cases where there's less of a concern about cognitive impairment and patients are receptive to patient education, you can always incorporate a teach back into that education process so that we're not just talking at the patient and telling them to stay in the chair, but rather we're having a little bit more of a dialogue about, here is why we need you to stay in the chair and why we need you to use your call light or let us know, before you need to get up. That way we can help connect the dots for the patient about the reasons why it's important to call before they get up.
Mm-hmm. I guess I'm just kind of looking at a list of different interventions too. I guess the only other one that jumps out at me for this particular issue would be also handoffs. And so making sure that, say if therapy is PT or OT just gets done working with a patient and has a patient back in the room, making sure that then there's a handoff that's, the nurse or the CNA knows, okay, we're done working with a patient. We left, Mr. So-and-so in room 23 sitting up in the chair. Just so that it's, everybody knows where that patient ended up and that you are exiting the room, potentially even the floor at that point in time. So that would be a handoff between staff would be important for those patients as well. Any other tips from the audience about those chair transfers and falls?
This is Amber. I like the idea of repositioning. I know a lot of times that's just when patients are in bed, you got to reposition them, but that doesn't necessarily mean that they don't need to be repositioned in the chair too. So whether it's like standing up every so often or just kind of getting them moving. So, that can prevent a lot of things, pressure ulcers. It can help prevent falls because they're moving more frequently. They're not bored. So I just like the frequent repositioning idea a lot.
Yeah, for sure. I'm sure all of us have experienced like bleacher butt at some point in our lives if we're sitting at, sporting events or concerts or whatever. And yeah, we have to shift around all the time to make ourselves comfortable. And some of our patients can't physically do that very easily.
And feeling uncomfortable in the chair may be the motivation to try to get up or try to self-adjust.
Exactly.
Well, this is Dana, and I have something to, I guess maybe we can talk about. But so when I used to work bedside or in a hospital setting, we try to do a lot of education across the organization about if somebody was at high fall risk, that everyone knew that. So if they saw that patient up, that they were empowered to stop and at least stand with the patient. Is that still kind of what they would consider a best practice? And how does that look for organizations, I guess, as far as, I know non-clinical people get a little bit clammy when they walk into a patient room, but is that still something that I guess is kind of a best practice, or has that kind of gone away from?
No, I mean, that's something we definitely would still recommend is making sure that your entire organization knows some of the signage that your hospital uses to indicate whether somebody's at risk for falls. So, that could be, the falling leaf on the door, maybe it's a star, or whatever signage you've developed, either in the room or outside the door, or the patient's wearing a yellow bracelet or has the yellow socks on, or whatever it is, whatever that visual indication is, making sure that everybody knows that, the housekeeping staff, the person who works at the desk, the maintenance people, just everybody knows what that means. It doesn't mean that you're expecting those non-clinical folks to actually intervene and physically assist that patient. But if they see that patient is starting to struggle to get out of the chair, or maybe they're already up and moving around in the room and they're not supposed to because they're identified at fall risk, they can be empowered to, they can identify that, and then they can go find somebody who can help. So find one of the staff on the floor, the patient care staff, who can go in the room, because maybe the alarm failed, or maybe that person didn't have an alarm and they're getting up on their own. So the non-clinical staff don't necessarily have to do anything physically, but they can at least go be the runner to go get help. Assuming they know what those, like I said, the signage and things like that mean. So.
It's one of the first things that we did when we started the Capture Falls program, was that not just nurses are accountable for falls, but everyone in the organization, and just really promoting that across the organization. If people know about assisted falls, and if people know what their fall rates are and that type of thing. So it's not just a nursing centric issue.
And how do you engage, say, family members in your fall reduction program, as we try to become more partners with our caregivers and family members that are with our patients? What does it look like to engage them in the process?
Can anyone give some examples of what they're doing in their organizations that is working well?
This is Amanda again from Saunders. I feel our team does really good with this. We do interdisciplinary stand up in the morning with PTOT, speech, social worker, pharmacy. And we look at everything as a whole. We talk about barriers with family and education needed. And then we work as a team kind of separately and together. They'll work, therapy will know that the education's needed and communicate back in charting and with the nursing staff. We also do specifically more on swing bed, but we have had care plan conference with family, even on acute patients, if we're running into some barriers with education with family. And then we'll have the interdisciplinary team talk with family and answer questions and give education.
Yeah, I mean, I would, that sounds really great. What you just described, Amanda. And so, using family along the way, that family, like even at admit, that family can provide sometimes the family members are better at providing some of the history of like the mobility and falls, and if the patient was already having problems at home with falls, sometimes our families are better historians by far than our patients. And so making sure that, you know, even as you're doing your fall risk, if you could gather some information from your screening, if you can gather some information from the family, because let's face it, also the family is sometimes more honest about those things than the patients are, as well. That the patient themselves, even if they are a good historian, they may purposefully leave some things out. Know this from my own experience with my own family. So even, you know, from the get-go and then along the way, you know, to pull family in as needed, with input, or, you know, that family, it's been different with COVID because a lot of hospitals have had restrictions on visitors. And actually there's a little bit of research that's been coming out lately that shows that fall rates have gone up, and part of it speculating that it might be because there's less family visiting, and like the family members are kind of your eyes on those patients sometimes. But the family, if you pull them into the patient education, the family can help reinforce some of the messaging with the patient. Sometimes the family needs to be educated just as much as the patient. And so teach back might be not just with the patient, but also with the family member. So the family member understands, you know, why it is that the patient needs to use the call light, or whatever intervention you need to educate them about, is good. Some hospitals that we've worked with before have also incorporated family when able into post-fall huddle discussions. So that is a way that some hospitals have incorporated family members into these issues. And then I'm also aware of some hospitals in the state that have like family advisory boards. I'm not sure exactly what they call them, but it's basically like a community, you know, community members are advising the hospital on a variety of issues, but falls being one of those. And so, you know, having some family member input on, maybe they're giving you feedback on your patient education materials, like on the readability and accessibility of those. Or maybe they're just giving you feedback on your falls program in general. And a number of other issues, no doubt, that the hospital is working on at that time, but that's another way that we're aware of that hospitals are engaging families.
Amanda, you have been great to speak up and tell you about the experiences. Just one more thing I want to ask you. We know your program didn't develop just like overnight and suddenly you had this good engagement with patients and families. That was it kind of a journey to get there, or how did you get to this point where you feel like you have that strong education within your hospital?
So actually, I cannot take all the credit on that. I've been in this role for just right at a year. And so the team that I have now that's working together with me to kind of facilitate this again for re-engagement, they were part of this initial education and that journey. Actually, I think, oh boy, it's been at least a couple years ago. And so it was kind of a general consensus that, yeah, you know, we could definitely brush up our skills on it. And like I said, I think that the education and the process that were put back in the beginning were just really solid. It's just getting that back on everybody's forefront again. And so far, it's been really good. You know, you always have a few that maybe aren't completely on the boat, but we'll get there.
It's great. Thank you so much.
I had one other thought back to the, you know, family engagement with fall risk reduction. With my interest in teamwork, you know, one way we can frame this for the family member is to make sure that the family member feels like and knows that they are a part of the interdisciplinary team. At times just as valuable as many of our healthcare professionals are. So being really clear with the family member about, you know, what their role is when it comes to patient safety and kind of what some responsibilities you might, you know, give to them as a member of the team to be another set of eyes for you while they're in the room with the patient, kind of everything that Dawn had mentioned earlier about speaking up and sharing history, or perhaps honest assessments of a patient's abilities. All of those things can help, but to the extent that family members don't feel like they're necessarily visitors, but they feel like they really are a part of the team, can really go a long way to helping them engage fully with you through your, in your safety initiatives.
Vicki, I agree with you a lot on that. I appreciate everything that you said, and especially that care plan conference that we do with the families for our swing bed. I really value those. And I feel that the patients reciprocate that as well, along with their family members. And I think one good thing about our team is that they are comfortable with having some difficult, or not difficult, but hard discussions with family about patients' current care and what it's going to take. And like you said, being clear and concise about that, but really involving them on what matters to them and where their goals are at.
I just put a link in the chat to a PDF of a presentation that we did back in January of 2020. It looked like this is one of we do quarterly collaborative calls with the hospitals in the Capture Falls Collaborative. And so then we post these on our website. And so what I have is a link to that information. And so it's an overview of ideas for how to engage patients and families in fall risk reduction. And then also some examples of just how patients feel about fall risk reduction in general, and kind of their perspective, and what do they want to know, and kind of what are their thoughts. And these are qualitative research studies, so they were interviewing a relatively small number of people, so you can't necessarily assume that everybody feels the same way about fall risk reduction, but it was interesting. Some interesting nuggets came out of that, so you guys can kind of look through that. The slides are fairly self-explanatory, I believe, about it. So yeah, there's a lot of attitude on the part of patients like, oh, it's not going to happen to me. And interestingly, one of the things that people were most embarrassed, like they were more embarrassed about being incontinent than falling, like in these research studies, the patients were, which is getting off of the family engagement issue, but like people would rather end up splayed on the floor on their way to the bathroom than actually, be incontinent in their bed or in their chair. They would rather take the risk to try to make it to the bathroom on time. So I thought that was kind of interesting. What becomes a priority to people, especially if they feel like, oh, falls are something that happens to other people, not to me.
And Dawn, if I remember right from that literature, there is also an element of patients not wanting to feel like they were bothering staff. Yes. Like patients were acutely aware of how busy staff are and how many patients they have to care for. And so maybe less likely to ask for help or use the call light because they don't want to be a bother or or a burden or assuming that you're tending to other more important needs. Mm-hmm. When you couple that with this idea that falls happen to other people and not to me, that creates a recipe for people attempting to, get up and ambulate on their own.
Yeah. And even if you tell them, no, call for help first, but they see you all flustered and rushing around like with the chicken with your head cut off, because we know how busy you guys are. The implicit communication that your staff might be sending about their level of busyness might override any messaging verbally that you tell them, no, we really want you to call for help. So being careful about both your verbal and nonverbal communication to patients about that. Yeah, that was part of that research literature. So. This is great. This is like a great conversation. I love that it's like we're just covering all sorts of different things.
Yeah, feel free to either unmute and speak up with questions, or you can place them in the chat as well, and we can field questions from there.
Well, this is Dana again. I like to get all my questions answered, even though it's probably not my forum. But I've heard a lot of talk recently about kind of mobility teams versus kind of fall prevention teams and pushing more towards getting patients moving. So I guess what are your feelings on that? And is that something like a nurse's aide does? The PT is giving us a shout out over there. Because we all know, like you said, nurses are busy and all of us want to take time to rub our patients' backs and take them on walks, but truthfully, we just don't have time. So what does that look like as a good model, especially in rural hospitals? And what are your feelings just on that increased mobility? Is that making a difference in the fall rate? Kind of those kind of things.
Yeah, I mean, I don't have any research data to spout off for you to know to say like, oh yeah, if you get a patient out of bed X number of times a day, that they're gonna like their fall risk goes down by a certain amount. I don't think that kind of data is out there. But it seems to be fairly common sense that I know there's a lot of research data out there that talks about like the percentage of strength that people lose per day while in the hospital. And they move a lot less in the hospital than they were at home. And so sometimes their physical function is potentially worse than when they came in, because they're just more sedentary. And there's this tension, this competing tension. It's like, oh my gosh, we don't want you getting up on your own. We realistically don't have time to get you up a lot, because of all the other things that are going on. But yet we don't want you to get weak. And so it is this competing tension. I mean, patients are getting the messaging about, oh, we don't want you getting up very much. And so I would say you were right that trying to kind of flip fall risk reduction on its head and think about it in terms of like, rather than a fall risk reduction team, it's like you're also a mobility team and trying to promote mobility in your patients, because that is going to be better off for them in the long run. It's going to be better function for their lungs if they're upright. It's going to be better function for their muscles, their strength if they're out of bed and upright as much as possible. And so I would say that, making sure everybody who is involved in direct patient care knows how to assist a patient. And so getting your PT and OT staff, making sure there's annual competency training in terms of how do you use a gait belt, how do you assist a fall if one occurs, various transfer techniques, so everybody who has an opportunity to walk in that room has some basic skills on how to safely assist a patient with movement. And and then obviously, appropriate referral to PT and OT for patients. And, not everyone's a candidate for PT and OT, but many patients are. And so making sure that those referrals are happening and that those PTs and OTs are communicating with the nursing staff. There very well may be times that, if a patient is relatively safe, that some of that mobility can be delegated to potentially like a CNA. And, it doesn't have to be just walking for the sake of walking. I mean, like hourly rounding, for example, if that includes making sure the patient gets up and goes to and from the bathroom, that's walking, that's getting up and moving. And so taking those opportunities to make sure they're out of bed for meals and walking whenever possible, whenever feasible, and making sure that those rehab referrals are happening appropriately and making sure that everybody knows how to safely move patients. All of those things can foster that culture of mobility. So there's there's a group out of England, I want to say, that they call it PJ paralysis, like PJ, like hospital gown or PJs. There's some I know they've done some like webinars and things. I want to say it's out of England that have kind of that tagline, hashtag NPG paralysis, because again, the idea is to try to foster a culture of mobility as opposed to just letting people languish in bed and get weaker and weaker and weaker. So, because yeah, that's going to create a downward spiral, and you get issues with depression and lung function and pressure sores and all sorts of things. So
Yeah, I can't speak to this from the mobility standpoint, because that's not my expertise. But I was thinking, as you're talking about, I'm thinking about like some of the human behavior and organizational considerations that go along with that too. And, you know, in addition to the training, making sure all staff know how to safely transfer patients and use a gait belt. Also making sure that they have the self-efficacy to do it. So do they feel, you know, I know how to do it, but do I really truly feel confident mobilizing this patient if that's part of the patient's goals? Also, you mentioned kind of acknowledging that tension with, you know, mobility and safety. And I think that's a real conversation that has to happen, especially if the mindset has been, do what we need to do to minimize risk of falling for this patient. But now we're also asking you at the same time to do things that might increase their risk of falling if we're not properly mobilizing patients. So having honest conversations with staff about, you know, the opportunities that are present there, but also some of their concerns and reservations, I think would help set you up for success with that. And then the other piece I wanted to connect this back to is from an organization and a cultural standpoint, how do you frame the occurrence of assisted non-injurious falls? If you frame we don't think that any falls are good, but assisted non-injurious falls are better types of falls than an unassisted, even non-injurious or injurious fall. So if we are framing and talking about assisted non-injurious falls in a really punitive manner, I think that's a cultural influence that would make it really difficult to get these mobility types of teams and programs off the ground. Because now there's a fear that if these types of better falls happen and I'm reporting them, like, will that be held against me? And how do we track that in our fall rates for our facility? So my 2 cents on that topic as well.
yeah, that's a great point. I mean, if you are getting people up and moving a lot, and they're at risk of falls, sometimes they're going to have to be lowered to the ground. And so even if they're like, you know, they start to lose their balance, you're walking them in the hall and you're supporting them against your body with the gait belt until somebody else can bring a chair. It's like, well, technically that's a fall. It's an unplanned descent to a lower surface. It was an assisted fall. It was very controlled, and it's very much less likely to result in injury than an unassisted fall that is happening where the patient's like in the room by themselves and you don't even know they went down. So those assisted falls are a win, because you are with the patient, you are getting them up and moving, which is a great thing. You are assisting them appropriately, and you are aware that they need your assistance. And yes, maybe they go down and you're lowering them down to the floor or the bed or a chair. And it's going to count in your total falls, but those total falls are a mix of the good and the bad. It's the bad things are the unassisted falls, and an assisted fall really is evidence that your system is working. Because your staff knows what to do, you were with the right patient at the right time, and you had the right skill set to help them. And so, yeah, that should be looked at as a positive thing, not as a negative thing in your fall rates. So we would say like the unassisted fall rate is really the fall rate that you should be worried about, not necessarily the total fall rate, because the total fall rate is going to incorporate both those good and bad falls. There was a message in the chat about patients with sundown syndrome. We all know that night shift doesn't necessarily have extra staff to work with patients. And so that is a big challenge. So I guess I'm going to open this up to the group first and see if anybody has some good suggestions, because that is probably the most challenging patient population there is. So I guess, yeah, nobody has a great answer for those challenging patients. I guess my advice would be, some of the things we started talking about when we were talking about the unplanned transfers out of chairs. And so, alarms possibly, although sometimes that can agitate people more, and almost make the situation worse if agitation is a problem. So consider alarms, consider proximity to the nurse's station, consider video monitoring, making sure that patient is physically comfortable, rounding frequently to make sure that needs are met. Maybe talking to the OT staff, and I know some hospitals will put together kind of like activity kits just to keep the patient engaged and busy with something, and so, that could be, stress balls or, just things that the person can manipulate with their hands and do to keep them engaged and kind of entertained and busy, so that they're not going to get up and wander around. Frequent movement of those patients, so getting them up and walking as much as possible as staffing would allow would be something else, would be another idea. So trying to look on our website to see if we have any other resources specifically for that.
Well, and for any hospitals that have done like the age-friendly cohorts, it's kind of interesting how all of that seems to intertwine, because there's the mobility piece, but then there's also the mentation and the medication piece. So how all those things play into the potential for fall risk, and making sure that we're looking at a patient in its entirety, not just, oh, they're kind of shaky on their feet. Okay, but what is their mentation? Do they get restless in the evenings? What, to really look more holistically at our patients and not just, yeah, they're a high fall risk and kind of leave it at that. So I think that individualized kind of care planning is super important, because, and that's too where I think you can engage family. Like if from 7 to 9, they're really restless, can you see if they have a family member that could come spend some time with them during that time, or things like that. So I think it's interesting how all of those things can kind of intertwine to create the perfect storm for falls or other things like that.
And then you throw them into an unfamiliar environment.
Mm-hmm.
That makes it hard too. So I just put a link in the chat. We have a page specific. It's not specific to sundowning, but it's a page for interventions to consider for patients with cognitive or emotional impairments. And so, sundowning is kind of a very specific issue, but it's indicative of cognitive and emotional impairment. So there are a lot of the things that we talked about. Yeah, like the medications. That's something that until Dana mentioned that hadn't even occurred to me until I saw this, until she mentioned it, and like, oh yeah, we have that listed as an intervention. So making sure their meds aren't contributing to the problem would be important. So.
Well, does anybody else have questions or comments or things that they're doing that's new and upcoming in their hospitals, or things they want to offer to the group? We've about filled our hour. Good job, guys.
Yeah. And I was going to say, we're almost at the hour. Mm-hmm. We can take any final questions. We just have a couple wrap up slides as well. We'll go through the wrap up slides, and then if any other questions come up, feel free to speak up or drop them in the chat. So action items for you between the end of our session today and our next session, which is on September 29th, are to finalize your tools and plans, et cetera, for conducting an audit, which we highlighted in session 3. So if you missed session 3, please be sure to watch the recording for that in detail. And what we'd like you to do is to conduct that audit of whatever fall risk reduction problem, issue, intervention, et cetera, of your choosing. And just come prepared to share your experience with the auditing process with us on September 29th. Something we didn't put in the slide, Anna Dawn, which we should have after we talked yesterday, was a great time to do your audit would be next week if you haven't done it already, because next week is National Falls Prevention Awareness Week. So that next week would be, if you haven't already, would be a great opportunity to either finalize your tools or actually go ahead and launch your audit. So it could serve two purposes. You can conduct your audit, but also help promote National Falls Prevention Awareness Week as well. So our next session will be, it's Wednesday, I believe, September 29th, same time, noon to 1 p.m. Central Time. We'd like you to come prepared to discuss your experience with auditing and your auditing process. And we will send out some questions for you to reflect upon and think about in advance, a few days in advance, so that we can stimulate discussion for that session. We'll also talk about kind of what can you do with what you've learned from your audit, and how you can translate that into action using a PDSA process. So we'll kind of help you connect what you've learned to a quality improvement methodology to keep you moving forward with improvements in your fall program. And then we'll set aside some time for some topic specific education. Topic is TBD at the moment, as time allows, because we want to make sure we have ample time to discuss the auditing process and experience and help you connect that to the PDSA cycle as well.
And to be clear, like we aren't expecting anybody to share their actual results. Like we don't need to know like, oh, hospital X in anywhere in Nebraska had a 60% compliance rate with gate belt use. Like we don't need to know that. We want to talk more about the process of doing, the audit. So, we'll send the questions out in advance, but it's going to be things like, what did you decide to audit and who did it and how did you choose your patients, and what changes are you thinking of making based on the results, and linking that to that PDSA cycle. So we're not asking anybody to disclose their actual data of the audit. So yeah, if anyone was nervous about that, don't have to worry about that.
All right, in the meantime, our contact information is here. So if there's anything we can help you with, or if you run into challenges with your auditing process, don't hesitate to contact us between now and our next session on the 29th. Dana, anything else for the good of the group?
Not that I can think of. No, I think you covered it all. So thank you.
All right. Well, with that, we'll wrap up for today. Thanks for your engagement and your questions today. This was a great technical assistance session. And we will look forward to seeing you all again on the 29th.
Thanks,
you, guys.
everyone.
Thanks.